Okay, so we are going to talk today about the long-term complications of diabetes. We're going to discuss the rationale for the prevention of long-term complications of diabetes and discuss an approach to screening, diagnosis, and treatment of the long-term complications of diabetes. So just a quick overview, we'll initially talk a little bit about background, and then we'll go into some of the landmark studies that have really kind of shaped the way we deal with a lot of these complications, particularly retinopathy, nephropathy, and neuropathy. And then we'll talk a little bit about macrovascular disease. And then we'll get into some of the other complications of diabetes like musculoskeletal or skin manifestations that we can often see associated with diabetes. So just a little bit of background. I always find this slide to be interesting. So there's approximately 233,000 deaths per year related to diabetes annually in the United States. And of those patients, approximately 1.8 are death from any cause, 1.25 is death from cancer, and 2.32 is death from vascular disease, and 1.73 is death from any other cause. So I also find this interesting. So when people survey Americans and they say, what are your biggest fears? Diabetes actually makes the list. It might be at the bottom of the list, but it does make the list. So about 3% of people are actually very fearful of getting diabetes. And interestingly, shark attack is also on the list. So it's right below shark attack. But, the more typical stuff like cancer and plane crashes, which makes sense, it's interesting that diabetes makes the list. So, Okay, so this is something that you guys probably will typically do when you're in the outpatient setting. But how do we monitor these patients, and what kind of things do we want to check when we see them in clinic? So you want to make sure that you're doing a blood pressure at every visit. In terms of a dilated eye exam, so for our type 2s, we say that you want to get that at the onset of diagnosis and then annually after that. For our type 1s, we typically don't necessarily get it right at the onset of diagnosis because we don't think that the type 1 diabetes has been lingering for very long, unlike the type 2s. So we usually recommend about 3 to 5 years after onset. Obviously, we want to do a foot exam annually and at every visit if they have signs of peripheral vascular disease or neuropathy. Annual dental exam. Diabetics tend to have more severe periodontal disease. And then lipids annually, and if they're low risk, so if you have like a 20-year-old type 1 diabetic who's pretty low risk, then probably every 5 years or so is sufficient. And then urine microalbumin to creatinine also annually. I disagree a little bit here where I'll do it for type 1s and type 2s at the onset of diagnosis just so that I have a baseline for comparison. They should have the influenza vaccine annually and then the Pneumovax at least once. And also Hep B. So I think Hep B is something that we often forget about in our diabetics, but the Hep B vaccine is also important. So let's talk a little bit about some landmark studies. So this is the Diabetes Control and Complications Trial, also known as the DCCT trial. And this was basically an NIH-funded trial. It was done from 1983 to 1993. And it's probably one of the largest, most comprehensive studies that's ever been done, honestly, for diabetics. And what they did is they looked at the effects of 2 treatment regimens. So they looked at standard therapy and then intensive control therapy on complications of diabetes in people that have type 1. So this was only a type 1 study. And just to give you a sense of what intensive control meant, they basically kept the A1C less than or equal to 6%, which as you can imagine is pretty tight. And so what they discovered from this study was that essentially good glycemic control is absolutely necessary if you want to reduce the risk of diabetic complications. And then they also showed that the risk of microvascular complications, so things like retinopathy, nephropathy, and neuropathy, increases as your A1C increase. And it's a fairly proportionate increase. So if you look, as you go up in your A1C by point from 6 to 7 to 8 and so on, the relative risk actually increases. So you're able to decrease retinopathy by about 76%, nephropathy by about 50%, and neuropathy by 60%, which is pretty phenomenal. So So it's really important, even at the onset of the diabetes, to really hone in a lot of the stuff for our diabetics. After the DCCT trial, they actually did an extension of it called the EDIC study. And what they looked at here was what happened to those patients really early onset in their disease process. So what happens if you really do some intensive therapy at the onset of the diagnosis of the diabetes? And honestly, what's interesting here is what they found is that our body has something called metabolic memory. And with metabolic memory, you can actually have even further risk reduction that lasts long term. So it's not just to kind of control these patients. And it also did reduce the risk of non-fatal MI, stroke, and death from cardiovascular disease. So there was about a 57% risk reduction. And remember, this is just in type 1s. So then we'll shift gears a little bit to type 2. So in type 2s, there was a similar study that paralleled the DCCT study, and that was called the UKPDS study. And so it looked at whether the intensive management of type 2 diabetes and controlling blood sugars resulted in a reduction of long-term effects as compared with standard care. And in this case, their intensive control was an A1C of 7 or below, and their conventional therapy was an A1C of about 8%. So not a huge difference, but enough that we were still able to see differences further down the line. So like the DCCT study, the UKPDS study actually mirrored the findings in people with type 2 diabetes. So they had better glucose control decreased the risk of microvascular complications, as you would expect. What this study also showed us was that there is a need to manage these patients' blood pressure and cholesterol in addition to the glucose. So we call that the ABCs of diabetes. And then more recently, there's been some big studies that have also been undertaken to look at intensive glucose control in type 2 diabetes. And some of them have actually shown that it could have negative effects. And so the advanced study showed that the lowering the risk of new or worsening microvascular complications. So basically damage to small vessels that can cause kidney and eye damage. It also showed that it was associated with increased mortality in patients with long-standing diabetes and known cardiovascular disease. So in some situations, maybe having someone that's too tightly controlled can have more of a negative effect, especially if that patient is having a lot of hypoglycemia. And so that's kind of the overall point, was that you really want to try to tailor your glucose control to your patient. So if you have someone that's prone to hypoglycemia, that can actually be far more dangerous to someone than maintaining a slightly above average blood sugar. So just to take home points here, intensive glucose control in newly diagnosed type 1 or type 2 diabetes has benefits during the intensive therapy and has this legacy effect that we kind of talked about for later micro and macrovascular benefits. Optimal glucose management should start early and continue for as long as possible. And while the goal A1C is 7%, treatment should be individualized. And the other thing that I just want to point out here for you guys to remember is when you're seeing a patient in clinic and you see someone that has an A1C of 7, remember that A1C is an average. So that could be an A1C of someone who's averaging a blood sugar of 120 all the time, but it can also be an average of someone who's having blood sugars of 50 and then blood sugars of 300. So you really want to just remember that A1C truly is an average. And so as endocrinologists, what we sort of look at a little bit more now is something called time in range. And that gives us a better sense of how often are they actually at that target blood sugar versus just looking at the A1C. Any questions up till now? If you guys have any questions, feel free to unmute yourself and ask. Okay. I do have a case here. Does anyone want to read this out loud for me? Any volunteers?
I can read it.
Thanks.
So we have a 24-year-old female with a 1-year history of type 1 diabetes, referred for improving glycemic control. Her hemoglobin A1C is 8.5%. She travels frequently for work and often fails to check her blood sugars unless feeling bad. She has frequent hypoglycemia with no specific pattern determined. She takes Glargine 15 units at night and Aspart 1 to 10 ICR, and her dad had an MI at age 48. Which of the following approaches would be most useful in improving the management of her diabetes? A, she should treat her episodes of hypoglycemia with 30 to 60 grams of oral carbs, followed by a recheck of her glucose. B, an insulin pump. C, because of her hyperglycemia, her pre-meal ICR should be decreased. D, you encourage her to improve her glycemic control, since improved glycemic control has long-term positive effects on cardiovascular disease. Or E, useful foods and snacks for treating her hypoglycemia are orange juice, cheese, and peanuts.
Any thoughts?
So I guess we talked about the average. So she has frequent episodes of hypoglycemia, meaning in her A1C is still pretty high, 8.5, so she must have pretty high sugars. I feel like, I don't remember because we worked in clinic together, but I feel like in some of these people that have the really highs and the lows, they actually end up doing better with the insulin pump.
Yes, so that's definitely a good thought. In someone like this, you know, one of the requirements for an insulin pump is often they need to show compliance. And so she's, you know, in like the little blurb, it does say that she doesn't check her blood sugar very often. And so that wouldn't be an optimal person to put on a pump, but I think that's a really good thought. And then with A, we typically don't recommend patients using that much carb for a low blood sugar. So typically we recommend about 15 grams of carb. And what I typically tell patients to do is to either get glucose tablets from CVS and take 4 tablets, because that's equal to about 15 grams of carb, or the little kid juice boxes are also about 15 grams of carb. But 30 to 60 would be a lot. And 60 is typically what we tell our type 2s to have with meals. So the trays that you guys get in the hospital for all your inpatient diabetics, a medium consistent carb diet is actually 60 grams of carb. So that would be a lot for a low blood sugar. So A is out. B, we talked about. If we are to increase her pre-meal insulin to carb, if we decrease her pre-meal insulin to carb ratio, she would actually get more insulin. And so it would exacerbate her hypoglycemia. So that's not right. And then with E, useful foods for treating her hypoglycemia are orange juice, cheese, and peanuts. Also not ideal. Orange juice is a good option, but cheese and peanuts probably wouldn't bring up her sugar quickly enough. So the answer here is D. You encourage her to improve her glycemic control because this would probably have long-term positive effects on her cardiovascular disease. Okay, so let's talk a little bit about diabetic retinopathy. Okay, so I can just read this one real quick. Which of the following is true about intensive glycemic control in patients with diabetes? So A, it reduces cardiovascular mortality in type 1 and type 2. B, results in weight loss. C, was equal to blood pressure control in UKPDS and ACCORD in reducing diabetes-associated complications. D, will slow the progression of macroalbuminuria to end-stage renal disease. Or E, may worsen retinopathy initially, but reduces the progression of retinopathy with longer follow-up, long-term follow-up. So what's interesting here is obviously you guys already know that we want to screen our patients at least once a year with a dilated eye exam to look at the retina. So this one's a little bit tricky. The answer is actually E. So what's interesting is when you have someone that's incredibly hyperglycemic, if you all of a sudden bring down their blood sugars, it can actually initially make them have blurrier vision because their eyes have been so used to that higher glycemic content. When you rapidly reduce it, they initially have blurry vision, and then over time it does improve. But it's kind of contraindicated. It's not what you would necessarily think. So we talked about this already. You want to screen annually for retinopathy. You want to control the A1C, the blood pressure. There's some data that actually shows that fibrates will decrease your risk of retinopathy. The data is not great, which is why we don't typically use fibrates for retinopathy, but there's one paper in particular that does show that there's some evidence with fibrates. And so these patients should be referred to ophtho, where they can get laser photocoagulation, they can get intraocular injection of certain medications, or they can also undergo surgery. And so, screening obviously reduces the risk of blindness. So we said already that you want to screen annually in type 1s, and then at the diagnosis for type 2. And what's interesting is at diagnosis, about 20 to 40% of patients will already have some signs of retinopathy, which is pretty high. So it's really important to make sure that those patients are getting in with an eye exam early on. Okay, so what is the most common cause of severe vision loss in a patient with type 2 diabetes in the US? So A, vitreous hemorrhage, B, retinal detachment, C, macular edema, D, trauma, or E, cataracts. And the answer here is macular edema. And I'm going to show you a picture of what that looks like. So macular edema essentially is diffuse or focal vascular leakage at the site of the macula. And then the other thing that I do want to go over with you guys, and I do recall my internal medicine boards having sort of ophtho pictures where you had to identify what they were. So I would study those when you guys are studying for your boards. But there's two types of retinopathy, essentially. There's non-proliferative retinopathy and then proliferative retinopathy. So they both are associated with blood vessel changes. In non-proliferative, you'll usually get microaneurysms, intraretinal hemorrhage, vascular tortuosity, and vascular malformation. And in proliferative retinopathy, you'll get abnormal vessel growth or neovascularization. So you'll get the growth of new vessels. So when you look at images for both of them, on the left is non-proliferative and on the right is proliferative. And as you can see on the right, you have a ton more, you basically have neovascularization where you have an increased amount of blood vessel growth. So, I would know what those look like when you're studying for the boards. And we sort of already talked about this, but there's a 76% relative risk reduction if you control these patients, especially early on. And this is the study that I was talking about that looked at the fibrates. So intensive glucose control and the combination of a fibrate and a statin reduced the rate of progression of diabetic retinopathy. Interestingly, blood pressure control actually did not. So, there's one paper on this. We don't typically do this in clinical practice, but I think it's just an interesting thing to know. So let's shift gears a little bit to diabetic nephropathy.
This is a 28-year-old female with a 15-year history of type 1 diabetes. She moves to DC. Her initial hemoglobin was 8.1%, and she had a urine MACR, microalbumin ratio of 45, which is greater than normal 30, and it was previously normal. So which of the following statements should be part of your advice? A, ESRD develops in 50% of all individuals with longstanding type 1 diabetes. B, she has moderate risk, 10 to 20% of progressing to diabetic nephropathy, macroalbuminuria over the next 5 years. C, start with either an ACE or an ARB and check her microalbuminuria in 3 to 6 months. Or D, her abnormal tests may spontaneously resolve or may return to normal with glycemic control and other measures. I have lots of thoughts, none of which I'm sure are correct, but potentially C, given that she has an increased microalbuminuria, starting her on ACE or an ARB.
Yeah, so that's a good thought, actually. So the only concern is giving a young female of reproductive age an ACE or an ARB. So we typically want to avoid that just because they can be teratogenic. So I probably would not do C, just given her age. What's interesting here actually is that the take-home point here is that her abnormal tests may spontaneously resolve, or it may return to normal with glycemic control and other measures. So one thing to always remember if you do happen to see a patient that all of a sudden has an elevated urine microalbumin is you want to repeat it, because there are reasons that someone can have transient albuminuria. So any major exercise that's fairly recent, a UTI, a fever, decompensated CHF, if a woman's undergoing menstruation, or if there's an acute severe elevation of the blood glucose or the blood pressure, that can actually lead to an increase in the urine microalbumin. So if I ever see that, whenever I see the first time their microalbumin is elevated, I'll always repeat it like 3 months later, just to confirm that it's actually elevated. And so you guys know this, the stages of diabetic nephropathy, right? So normal is less than 30, microalbuminuria is 30 to 299, and then anything greater than 300 is macroalbuminuria, and that's essentially overt nephropathy. And then the stages of CKD, I think you guys know this as well, so we don't have to go over that. So how can we reduce the progression of diabetic nephropathy once it's been diagnosed? So obviously you control the sugar, you control the blood pressure, and then like we just discussed, you want to start them on an ACE or an ARB, except for young women of reproductive age, unless you have that conversation with them where they understand the risks and they say to you, like, I am absolutely not going to get pregnant. So this goes back to the DCCT study again. So if you recall, there's about a 34% relative risk reduction in microalbuminuria. And then also, this is old data, but also very good data, is that ACE inhibitors in patients with type 1 diabetes that have microalbuminuria does actually reduce the progression to clinical proteinuria. And so ACEs and ARBs do help. And this is an evidence that ARBs also help in both type 1s and type 2s. So they do work. And so you want to get, whenever, if you have a patient that's hypertensive, that has diabetes, it's best to put them on an ACE or an ARB right off the bat. And then screening, we talked about kind of already, so I can skip over this. And then management of CKD and diabetes. So we typically are going to get a BMP every 6 months or every year at the minimum. So always look at their creatinine. If their GFR dips, I do tend to refer to nephrology on the earlier side, just to make sure that they're getting plugged in case anything progresses more rapidly. And then just, a side note on diabetic nephropathy and what medications we can use. So I think this comes up a lot in the outpatient setting, is that you have a patient whose creatinine's a little bit elevated. What do you do? So the data on metformin is slightly controversial. I typically, if I have someone that has a slightly elevated creatinine, I'll honestly just avoid metformin, because we do have so many other good options on the market now. The DPP-4 inhibitors, so those are the ones that end in gliptin, so sitagliptin, linagliptin, those can be renally dosed. You do have to dose reduce them based on the GFR, but they're completely safe to use. As are the SGLT2s and the GLP-1s, as long as their creatinine clearance is typically above about 45. And then, of course, the sulfonylureas are also safe, but then if their creatinine is a little bit higher, just remember that it does increase their risk of potential more severe hypoglycemia. And then insulin is fair game too. The other thing to always remember is if you see a patient who all of a sudden has a dramatic reduction in their insulin requirements, always look at their creatinine, because that could be indicative of renal failure. Because usually patients in renal failure aren't clearing their insulin as well. And so their insulin requirements might go down. Any questions up till now? Okay. All right, I'm actually going to skip this question. Okay. So diabetic neuropathy. So interestingly, after about 26 years of type 1 diabetes, patients are at increased risk of diabetic neuropathy, whereas about 50% of patients develop neuropathy in type 2 diabetes. And most of our diabetics are not going to have painful neuropathy, so only about 20% have painful neuropathy. And typically they'll get, a distal and symmetric sensation of numbness or tingling, like in a stocking glove distribution. And the reason for that is because the large fibers are the ones that tend to get the most effective, and so those are our longest fibers in our body. So a lot of patients will complain of numbness, tingling, poor balance, and then that can progress to burning, stabbing, and electric shocks. On physical exam, you always want to check their reflexes, check for proprioception and vibration, and then do the monofilament test as well. So I'm sure this is, hopefully you guys all have a little monofilament in your white coat that you can use on your diabetics. But you do the monofilament test, and these are the little circles are the points where you should be checking with the monofilament. And then the other thing to always do, which I'll admit we're not so good about doing this either, is using a tuning fork. But you do the best you can. And then significance of early detection in the treatment of neuropathy. So the other thing you want to remember is you want to rule out any possibility of non-diabetic neuropathies. So one thing to remember is patients that are on metformin are also at risk of developing B12 deficiency. So if you have a patient with neuropathy that's on metformin, just check a B12 level to rule that out. And up to 50% of peripheral neuropathy may be asymptomatic. And in that case, patients are at risk for like insensate injury to their feet. So you always want to make sure that you're also counseling your patients to check their feet nightly on their own. And then the other neuropathies to remember too would be autonomic neuropathies. And these are a lot more tricky and challenging to diagnose. So for example, cardiovascular autonomic neuropathy also follows a distal to proximal pattern. Some of the symptoms can be a change in heart rate, resting tachycardia, abnormal blood pressure regulation, or orthostatic hypotension. And orthostatic hypotension actually tends to be a later stage. The differential includes anemia, thyroid disease, cardiovascular disease, adrenal insufficiency, dietary, medication side effects, and the diagnosis is done by cardiovascular reflex testing. And so I'll usually send these patients to a cardiologist, but again, this does tend to be a diagnosis of exclusion. And similarly, GI autonomic neuropathy can actually be pretty challenging to diagnose as well. But these patients will present with gastroparesis. They'll have some nausea, vomiting, bloating, feeling full early, so early satiety. You do want to consider gastroparesis in patients that have a lot of glucose variability and severe hypoglycemia. So typically the pattern is if they're on pre-meal insulin, they'll have hypoglycemia early into their meal and then have late hyperglycemia. And the way to diagnose this is with a gastric emptying study. And you want to avoid GLP-1s in these patients. So, Byetta, Victoza, Trulicity, Ozempic, because they can actually exacerbate the gastroparesis because they do tend to make the patients feel more full and it can worsen it. One trick that I like to use in these patients is if they're on insulin, if they're on short-acting insulin like Novolog or Humalog, I'll tell them to dose that at the end of the meal because that way they can not have that early low and then the late high. So if you dose their insulin at the end of the meal, it helps them a little bit better. The other thing you can do is put them on regular insulin, since regular insulin is a little bit longer acting, and you can dose that at the beginning of the meal. So this is again just showing that the reduction of neuropathy with intensive glucose control and standard versus intensive therapy. And I already went over this with you guys about B12. So other conditions to rule out, like I said, B12 deficiency, uremia, hypothyroidism as well. You want to optimize their glucose control. Sometimes painful neuropathy can be tricky to treat. But you want to, again, just remind them of how to manage their pain. And in my many years of being an endocrinologist, I have yet to prescribe an opioid for painful diabetic neuropathy. So what medications work? So pregabalin is actually quite effective and it is FDA approved. Gabapentin as well. Duloxetine is also FDA approved, which works well. So I tend to stick to those three. Sometimes I'll use amitriptyline. But I find that a lot of the other stuff doesn't work, like the lidocaine patches or the opioids. They're just not very, very effective. And then we talked about this, just making sure that your patients are looking at their feet and their nails and getting them cut properly and just inspecting them. Any questions up till now about microvascular complications of diabetes? Okay, so let's shift gears and talk a little bit about macrovascular disease. So we know this, right? The absolute risk of an MI is higher in patients that have diabetes, higher in men than women, but it's high, right? So we know that. And so one of the reasons that we really want to control our diabetes in our patients is so that we can reduce some of these cardiovascular events. And we do think that the risk for cardiovascular disease actually begins before even the onset and the diagnosis of diabetes. And patients that have diabetes for at least 15 years have a really high risk of CAD, almost about 50%.
Excellent. So this is a 66-year-old with type 2 diabetes for 14 years, here for a follow-up. Takes metformin, pioglitazone, previously on glyburide, glargine 42 nightly, aspirin 81, simvastatin 20, lisinopril 10, hydrochlorothiazide 25. Had an MI 5 years ago. Very focused on A1C, which personal target is less than 6.5. Exercising, diet is reasonable, trying to lose weight, no retinopathy. A1C is 6.7. ACR is 28. Potassium is 4.3, creatinine 1, TC 188, LDL 107, HDL 37, triglycerides 218, blood pressure 143/84, heart rate 76, BMI 34. So then they're asking, what is the next step? So this is a 66-year-old on metformin, pioglitazone, glargine. Okay, and then A is add rapid-acting insulin before meals, or you can restart sulfonylureas. B, C is increase lisinopril and simvastatin doses. D is DC pioglitazone and start
It should say glimepiride.
Okay.
Yeah, sorry.
And then E is DC pioglitazone and start 30 or 70/30 BID. I mean, A1C is 6.7, which I think is pretty good for someone who's a type 2 diabetic.
Yeah.
So I'm not, and then what this person is on already is working for them. I wouldn't really change that. I don't know what ACR is. ACR 28.
Where is that? Oh, that's the microalbumin creatinine ratio.
Oh, okay. I guess I would, and blood pressure is elevated. I guess I would do C, increase lisinopril and simvastatin.
Yeah, so I think that's the right thing, right? So their blood pressure and their LDL is a little bit above goal, and so their diabetes is actually on point. And so what you want to do here is just kind of risk reduce them for cardiovascular disease. So increase lisinopril and simvastatin. Good job. Okay, so in general, we aim for a blood pressure of less than 140/90, an A1C of less than 7, but again, like I said, that should be individualized per patient. And then we generally recommend a moderate intensity statin for diabetics that are ages 40 to 75. So that's atorvastatin 10 to 20 or Rasuva 5 to 10. And obviously for our higher risk patients, you go to a higher intensity statin. You also want to consider aspirin therapy for primary prevention of type 1 and type 2 diabetes. And anyone with a history of cardiovascular disease as secondary prevention. Stop smoking, right? So that's another thing that you want to tell your patients to do. And then one thing that we're also not quite as good at is screening our patients for peripheral vascular disease. So ask about claudication symptoms, look at their pedal pulses, and then consider an ankle brachial index if they're above 50 and they have risk factors for peripheral artery disease, like a history of smoking, hypertension, hyperlipidemia, or if they've had diabetes for more than 10 years. And so that's actually a large subset of our population, of our patients. And we probably could do a much better job of screening these patients for peripheral vascular disease. And then you tell them, quit smoking, you work on blood pressure, glycemic, antiplatelet therapy, different medications, and then eventually send them to surgery if necessary. And then cerebrovascular disease is a strong independent predictor of risk and stroke in and of itself. And so diabetics are at much higher risk of having cerebrovascular disease as well. And so the other thing that is literally like a whole other lecture that I could talk to you guys for another hour about is some of the drugs that now we have on the market that have been shown to decrease some of our cardiovascular events that are also important in treating diabetes. So definitely the SGLT2 inhibitors. So if you have a patient that has known cardiovascular disease and has diabetes, putting them on an SGLT2 inhibitor, like, so those are the ones that have flow in them, right? So empagliflozin, dapagliflozin, also decreases their risk. And so those are awesome second lines to metformin. And the GLP-1s, which are the liraglutide, Victoza, Byetta, Ozempic, they also have been shown to decrease cardiovascular risk. And so they're also great second line to metformin in those patients, especially your patients that are overweight. So that could be another lecture, but just wanted to throw that in there. So now let's talk a little bit about some of the other complications of diabetes, like musculoskeletal complications. So these patients are at a higher risk for things like carpal tunnel syndrome, Dupuytren's. They can get frozen shoulder, OA, gout. They can get muscle infarctions. I actually had a patient who initially presented with type 1 diabetes after having a muscle infarction. And so, things to just keep in the back of your mind. This is an example of a Dupuytren's contracture, and then Charcot foot is, of course, one of the complications related to diabetes that, especially at Georgetown, we see a lot of just given the limb service. And then some of the dermatologic manifestations. So they're at higher risk and they're more prone to bacterial and fungal infections. Of course, acanthosis nigricans. The other one is necrobiosis lipoica diabeticorum. And I do have a picture of that. And you might see this on some of your diabetics. So let me just show you guys that. So athlete's foot, fungal infections, acanthosis nigricans, which is right there. And then this is basically something that can be pretty pathognomonic of diabetes. It's a little bit harder to see on African Americans, but on African Americans, they basically have hyperpigmentation on their legs. And if you start paying close attention, I bet you'll see a handful of patients that have this. So in conclusion, the long-term complications of diabetes are associated with significant morbidity and mortality. And so prevention is key, right? So you want to really talk to them about those risks.